Hi, my name is Hallie Prescott, and I'm going to be presenting about the risk of aerosolization with respiratory support in COVID-19 disease. I have listed my disclosures here, including my funding and also relevant roles. And then I'm obliged to tell you that this talk represents my views, but not views of US government, Department of Veteran Affairs, or any other organizations that I'm affiliated with. I'm going to start with a little bit of background. I practice clinically in Michigan at two different hospitals, the Ann Arbor VA Hospital and then also the University of Michigan. The Ann Arbor VA is a smaller hospital with about 100 beds, and then University of Michigan is a large tertiary academic medical center with about 1,000 beds. And both of these hospitals are located in southeastern Michigan, just outside of the Detroit area, which was really one of the first areas in the states to be hit hard with the COVID pandemic. We had our first case on March 10th of 2020, and by the end of the March, we were having about 1,500 cases per day, and Michigan was the third state in the country in terms of COVID-19 deaths, behind only New York and New Jersey. And as we started to receive patients and transfer from these inner city Detroit hospitals that were getting overloaded, we really were sort of looking to the rest of the world to understand what were the best practices in terms of respiratory support for patients with coronavirus. We knew, of course, that SARS-CoV-2 was spread by respiratory particles and that these respiratory particles exist along a wide spectrum. So we have larger respiratory particles that are typically defined as greater than 5 microns or greater than 5 micrometers, which are called droplets. And these larger particles fall to the ground within 1 to 2 meters. And so typically patients only need, or healthcare workers only need to use face masks and face shields, essentially droplet precautions. But there are also smaller respiratory particles, less than 5 microns or 5 micrometers, which are called aerosols. And these smaller, tiny particles rapidly evaporate, but leave behind droplet nuclei, which remain suspended in the air and make it possible to have airborne transmission, which increases the sort of risk for transmitting COVID to healthcare workers. And when we were starting to think about, what were our sort of protocols going to be at these two hospitals, we found this report in the literature from Hong Kong, which had suggested against the use of non-invasive ventilation and against the use of heated high-flow nasal cannula, out of concern that these modes of respiratory support could increase the generation of aerosols, therefore increase risk of infecting healthcare workers and other patients. And for this reason, the authors recommended considering early intubation and mechanical ventilation for all patients who could not be supported on 6 liters nasal cannula. And so that was their practice, and that's what they recommended. And so at the two hospitals where I work, we spent a long time debating whether this was what we should do, sort of, proceed to early intubation versus considering the use of things like heated high-flow nasal cannula. On the one hand, the concerns for heated high-flow nasal cannula were this concern about increased aerosol production and increased infection. There was a secondary concern about, well, maybe people who get beyond 6 liters of nasal cannula are all headed towards intubation anyway, and that we are just delaying the inevitable by using heated high-flow nasal cannula. But that was really a secondary concern. The major concern among my colleagues was risk for aerosol generation and infection among healthcare workers. On the flip side, the pros, or sort of reasons to want to be able to use heated high-flow nasal cannula, were that it's just another tool in our toolkit. There was a lot of concern that we were going to run out of ventilators and run out of our ability to take care of patients during this pandemic. And if we are limiting our use of heated high-flow nasal cannula, that just sort of further constrains our ability to care for patients. The other pros are that, it's very possible that we would be able to treat people with heated high-flow nasal cannula and that they would be able to recover with this therapy, and that we would avoid need for invasive mechanical ventilation and subsequent, complications that come along with that therapy, such as ventilator-associated pneumonia, delirium, prolonged hospital courses. And so it's important to recognize when we sort of think through this problem that just with normal coughing, talking, shouting, the humans do produce aerosols. This study here suggests that the human cough produces respiratory particles with a broad range of size from 0.1 to 900 microns, and that 97% of the droplets produced by human coughing are less than 1 micron, so sort of squarely in this less than 5 micron threshold to define an aerosol. There was some prior studies in the literature that tried to sort of address this question about safety of heated high flow nasal cannula. In particular, this study here that was published in ERJ last year used mannequins. So these were sort of patient simulators that were able to simulate a variety of different lung conditions in terms of severity of lung injury. And in this study, the investigators used humidified high flow nasal cannula at 10 liters and 60 liters. And then they measured the exhaled airflow using smoke and a laser light sheet, which is depicted in that picture on the right of the slide. And across these different experimental settings, they found that the mean dispersion of exhaled air from these patient simulators was 172 millimeters, which is 7.8 inches. So relatively modest in terms of how far they saw airflow disperse. Around the same time that we were, again, sort of struggling with this clinical decision about whether to uniformly or sort of regularly treat people with heated high flow, there was this report in the New England Journal of Medicine in February or March of this year, in which the investigators had used a Goldberg drum, which is this kind of like rotating device pictured here, to create aerosols containing the SARS-CoV-2 virus, and then to test how long they could detect virus in aerosols and then on surfaces such as plastic and steel and cardboard. And they found that they were able to detect virus in aerosols up to 3 hours. The half-life was 1 hour approximately. And they could detect virus on surfaces such as plastic and steel for up to 72 hours and cardboard for up to 24 hours. And at least in the US, this study got a ton of coverage in the lay media, and I think really brought up a lot of concern about risk for spread of infection via surface contamination and also through aerosols. But it's important to recognize that, you know, in this study that the amount of virus detected decreased fairly rapidly. So even for this virus detected on plastic and steel 72 hours later, the amount had decreased approximately 1,000-fold. And it's unclear from this study whether the amount of virus they were detecting in the aerosols or on these surfaces was sufficient to cause human disease. So there was still a lot of uncertainty regarding the safety and the spread of SARS-CoV-2 in the healthcare setting. So because of this uncertainty and the sort of really desire to answer this question about whether we could safely use heated high flow nasal cannula, we partnered with some collaborators at our School of Engineering to do some aerosol testing. So we took 3 healthy human volunteers and we tested their aerosol production across 5 different scenarios. So first, them breathing and coughing on room air, and then breathing and coughing on nasal cannula with 6 liters of gas flow, non-rebreather mask at 15 liters of gas flow, humidified high flow nasal cannula at 30 liters, and then humidified high flow nasal cannula at 6 liters. And across each of these experimental conditions, we detected the amount of aerosols produced using 2 scanning mobility particle sizing systems. So these are essentially machines that are used in research for things like measuring exhaust from automobiles. So they're very sensitive in terms of their ability to detect very small particles in the air, and specifically are calibrated to detect particles in the range of 10 to 10,000 nanometers, which is 0.1 to 10 micrometers. So really sort of well poised to be able to detect the size of particles that we would be worried about in terms of risk of generating aerosols in the healthcare setting. And so you can see here that we had positioned this, these machines here so that we're detecting the particles that are produced right at the side of bed and then right sort of a few inches from where the patient is breathing, trying to simulate, you know, where a bedside nurse might be taking care of a patient. So here we look at the results from these studies. On the x-axis, we have the different sort of experiments that we ran or the different replications. And then on the y-axis, we have the mass of particles detected. So the different experiments across the first patient are shown in these black dots here. And the big takeaway is that this is a flat line. We did not see any increase in the amount of particles or aerosols generated across these different experimental conditions when we went from room air to nasal cannula to 30 liters high flow and to 60 liters high flow. We then repeated the same experiments on 2 different patients. The next patient 2 is again shown in black dots, and then patient 3 is shown in the purple triangles. You'll see that patient 3 across the board is at like a lower level, and we hypothesized that that's because patient 3 was tested on a different day, and there had been some construction going on sort of in a different part of the building from us when we tested patient 1 and 2. So we think that that may have caused some particles in the air. But the big take home is that across each of these 3 patients, we see no difference in the amount of particles detected, regardless of whether the patient was breathing room air, 6 liters, non-rebreather, 30 or 60 liters of high flow. We did run both positive and negative controls. So we used a HEPA filter here, and you see that there's a substantial reduction in the amount of particles detected. We also lit a candle in the room, and we separately used a nebulizer machine in the room, and those resulted in a substantial increase in the amount of particles detected, as we would expect based on how these machines are working. So based on these experiments, we felt comfortable, and we proceeded to use heated high flow nasal cannula standardly to support patients with COVID-19 disease, just as we would with other patients who are hospitalized for hypoxic respiratory failure. This is a more recent perspective study, a perspective piece that was published in JAMA, where they talk about the again, concern for airborne transmission with SARS-CoV-2, and the data and the understanding, of course, are still evolving to this day. Our current evidence suggests that droplet is really the main mode of spread, but I think there's still concern that there is this theoretical possibility, particularly in enclosed spaces, that there may be airborne or aerosol-based spread of disease. So in conclusion, we find that SARS-CoV-2 is spread by respiratory particles. We think droplets are more important, but certainly aerosols are going to potentially be part of the picture. We know that coughing produces respiratory particles across a range of size. And in fact, the vast majority of the particles produced by coughing fall squarely into this aerosol designation. We found that there was no evidence that heated high flow nasal cannula increased aerosol generation above and beyond what's already happening just with coughing and breathing. So we are now using heated high flow nasal cannula standardly with universal N95, eye shield, gown, and gloves for all patients with confirmed or suspected coronavirus. I would like to thank my collaborators on this work. So these experiments were led by my colleagues Jack Awashna and Margaret Wooldridge, and by many other collaborators at the University of Michigan. And then I'd also like to thank ISICEM for the opportunity to present today. Thank you.